From Microbe TV, this is TWiP, This Week in Parasitism, episode 202, recorded on January 13th, 2022. From Microbe TV, this is TWiP, This Week in Parasitism, episode 202, recorded on January 13th, 2022. I'm Vincent Racaniello, and joining me today here at the Incubator in New York City, Dixon Despommier.
Hello, Vincent and everybody. Since there are no windows, I can't possibly begin to tell you what the weather is like outside, except that when I did come in, it was partly cloudy and about 46 degrees, humidity about 50%.
Also joining us here at the Incubator, Daniel Griffin.
Hello, everyone.
And remotely from Glasgow, Scotland, Christina Naula. Welcome back.
Hi, good to be here. I can't tell you what the weather is like just now because it's pitch black outside, but I know it's not raining because the windows are dry.
So, Christina, you were supposed to come here for this. What happened? Just kidding.
I don't know.
Just kidding.
You blame it on COVID.
Well, it's good that you didn't because we can't fit any more people at this table. And that's because we have a guest today from the Febrile Podcast. Sara Dong, welcome to TWiP.
Hi, guys. Thanks for inviting me.
Hey, Sara.
Pleasure. You came down from Boston just to visit us, right?
I did. Got to
That's
make a
fantastic.
quick train ride.
Excellent. What time's your train back? We have to make sure we get you back.
It is at 7.
Okay, we got plenty of time.
Yeah.
Before we're going to find out a little bit of your history, but before that, I want to remind you that until the end of January, if you contribute to Parasites Without Borders over at parasiteswithoutborders.com, Daniel will match your donation and give it back to Microbe TV. That's us. Or you can go to microbe.tv/contribute because we are both 501c3s. Your deductions, no, your donations are tax deductible.
Yes.
I always say your deductions are tax deductible. Parasiteswithoutborders.com. You okay there?
I'm adjusting. I have this new microphone, or headphones. So.
Headphones, yeah. We need a longer wire for you. The Incubator is a work in progress, but we will slowly get to a point where you just sit down and things work. Not quite there yet. All right, Sara Dong, tell us your history. Where are you from?
Yeah. I'm from South Carolina. So I grew up there, went to college there. And so my parents are still down there. I went to med school also in South Carolina in Charleston, so a few hours away from where I grew up. And I couples matched for residency and ended up in Ohio for a couple years, and now I'm in Boston.
So when you were in college, did you already want to do medical school? Is that the idea?
I think I knew pretty early on. My dad is a emergency room physician, so I kind of grew up around it. And then I tried to branch out a little bit. I did the usual pre-med stuff and then Chinese studies in college to try and branch out. Mm-hmm. But I think medical school always was the plan.
Hard to escape the father pushing you to go, right?
He actually didn't push. I will give him credit.
Okay, good.
He might be listening. So. He's a wonderful, loving, supporting dad.
Yes.
Exactly.
Encouraging, maybe.
Yes. Yeah, they would have been fine with anything. But yeah.
I just want to ask one more thing. That is, why don't you have a Southern accent?
I don't. I think I may have had a few small words that I would have an accent, but I guess they've just slowly dissipated over time. But neither of my parents have a Southern accent, so I think that made a big difference. Okay. Yeah.
So you're currently a fellow, is that right?
I am. Yeah, I'm a adult and peds ID fellow in Boston.
So I don't know what that means.
Yeah. So for residency, I did internal medicine and pediatrics. It's a combined residency. Mm-hmm. And then when you go for fellowship, you can do adult, peds, or combined fellowships, depending on what your interests are. So I was quite lucky and met a couple different programs that would do the combined track. So basically, I do the same amount of clinical time, but the research time overlaps. So it is a 4-year fellowship.
So a fellowship is basically combining clinical and research time.
Yeah.
And it's 4 years. It's after the residency?
Correct, yeah.
And then do you go on and have a career doing both as well?
Hopefully. That's the plan.
Okay. So you could do the same with an MD PhD, right? But
Correct.
You're an MD, so you do a fellowship.
Yeah.
And it's in infectious diseases that you're doing?
It is. Yeah.
Any particular area?
I'm still kind of figuring it out. I do like transplant and immunocompromised hosts. That's kind of my clinical interest. And then I do like medical education. So I'm hoping to find a career that involves all of those, smush them together.
And which hospital in Boston are you at?
Beth Israel Deaconess and Boston Children's.
Very good. Okay, now I understand better. And so you're almost done with this fellowship, right?
Almost. I'm over the halfway point, but I still have
2 more years.
another year, almost 2 years, year and a
then,
half.
Well, after this, you would get a faculty position somewhere. Is that the plan?
Correct, yeah.
And you would have clinical duties, and you would have a lab, right?
The lab part, not so much, but I think I'll have a mostly clinical job.
And you could do clinical research, right? Clinical trials and that sort of thing, right?
Yeah,
All
yeah.
right. Got it. Thank you. So you have another interest, which is podcasting. We'll talk about that later.
Yeah.
We'll talk about the Febrile Podcast.
Yeah,
But the case we have this week was yours.
it was.
So let me bring it up on the screen here. I don't know, can you see that,
I can.
Sarah? There's the case, in my words, as Daniel recited it last time, right?
Yes, so for those tuning back in, or those tuning in for the first time,
Tell us about the case in your words.
So we had an older male over the age of 65 or so who came in with abdominal pain for a couple months that had just continued to get worse. He otherwise felt okay and hadn't really had other symptoms like changes in weight or major past medical problems or prior surgeries. And so just a little social background, he grew up in rural inland China. As an adult, moved to a larger city in China. So he did tell us that, he's active and healthy. He did eat a lot of fish and leafy vegetables, but he actually has lived in the U.S. for the past 10 years and had been doing well. And since he's moved here, he has no pets or no other particular things that stood out on his social history. And he is HIV negative, and his exam was unremarkable. So we got some labs back. He had an elevated white count, low platelets, normal hemoglobin without anemia, and on his differential he had predominantly neutrophils. Like everyone else who comes in the hospital, he had a workup and had a abdominal CT, which showed a new mass in his colon. And so to follow that up, he had a colonoscopy, the mass is resected, and they called me because the pathology showed adenocarcinoma, but there were also eggs in the sample. And so our extra clues were that the eggs were slightly ovoid and about 80 microns.
Okay, we did the case. Now we have some guesses.
We do.
So Dixon, can you see the...
Yeah, sure.
Why don't you start with that first one?
Yep. Cam writes, "Hi, TWiP team. New South Wales, Australia, 12 degrees C, 53F, partly cloudy with colder weather we have had here. You would think winter was still here. To cut a long diagnosis short, my diagnosis is strongyloidiasis with adenocarcinoma of the colon. And to go further, perhaps, even strongyloidiasis-induced adenocarcinoma of the colon. An infection with Strongyloides stercoralis, a genus of the parasitic nematodes. I'll try this. It's actually rhabdidiform nematode, can lead to cases of autoinfection. If left untreated, this can result in persistent infections lasting decades, leading to the development of a hyperinfection syndrome. Reasons. The eggs of Strongyloides stercoralis are large and ellipsoid, 40 to 85 micrometers in length. Fitting? Does that say fitting there? It's a little bit fuzzy.
fitting the 80 microns.
Fitting the 80 micrometer, slightly ovoid profile of the eggs observed in this case. I ruled out other infections like schistosoma japonicum. The eggs observed in this case, although as around and the right size for the parasite, such as Schistosoma japonicum, 90 micrometers by 70 micrometers, as japonicum, has a distinctly different appearance in the eggs. What has also made Schistosoma japonicum a suspect is that it does not occur in Southeast Asia.
Does.
Is that it does. I'm sorry. I'm having trouble. It does occur in Southeast Asia. And the case we are looking at is from China originally. And there are also examples of parasitically induced cancers, such as suspected case with a concomitance of S. japonicum infection and rectal carcinoid tumor in an asymptomatic patient. He gives a reference for that. Overall, trematode eggs are generally much too large to fit the profile, so that tends to rule them out. See attached egg size document from the CDC. Another reason for deciding it was Strongyloides stercoralis instead is that it has been implicated in colon carcinoma, adenocarcinoma, in other past cases. And he lists two references: parasitic infections, carcinogenesis, and human malignancy. See Table 1. I eliminated infection from parasites like liver flukes as possible causes, since that would tend to rule in cholangiocarcinoma and not be expected to be seen in colon adenocarcinoma. Egg structure and appearance would be consistent with Ascaris lumbricoides, roundworm, but egg-laying adult worms would be more than likely have shown up on the CT scan and aren't as implicated as parasitic infection-associated malignancy. The adult Strongyloides stercoralis being approximately 50 micrometers in diameter and between 350 to 600 micrometers in length would not show up as well on a CT as Ascaris lumbricoides worms that are massive in comparison. To confirm the diagnosis, serology testing via immunosorbent assay, ELISA, to test for larval antigens would be diagnostic. Treatment could be complicated due to the surgery for the adenocarcinoma. In this case, I would suggest deferring to the attending surgeon to recommend appropriate medications for the parasitic infection immediately post-surgically. Neutrophilia fits the case, though may also indicate opportunistic secondary infection, which should be checked for via signs such as fever or culture. Antibiotics, as appropriate, should be administered if indicated, plus normal therapy used without regard to the surgery. Ironically, some might say that the current climate, but the normal first-line therapy would be ivermectin, a much overused drug in recent past, and in a single dose, 200 micrograms per kilo orally for 1 to 2 days. Additional approaches to therapy would be albendazole, 400 milligrams orally 2 times a day for 7 days, ivermectin, 200 micrograms per kilo per day orally until stool and or sputum exams are negative for up to 2 weeks. I think in this case we can rule out all non-egg-laying organisms safely. It is not going to be a virus. I do not know of any egg-laying viruses. It would have to be a bloody big virus, and I am sure that Vincent would have told us all about this in class. Virology Live, 2 a.m. Thursdays, Oz time. Though, who knows what gems of knowledge Vincent will share with us all in Viruses Live, the, I am sure, most excellent advanced virology course to come in 2022. I can safely predict egg-laying viruses won't be among the gems, though. Lots of luck. Cheers, Mr. Ozzy Cam.
I'm thinking that was LOL, laughing out loud. Sarah, what do you say?
Up to interpretation.
Yes.
Sorry I stumbled through that, but that's...
I think the next one should be taken by Sara. What do you think?
That's written by Sarah. So Sarah, you go in.
So Sara writes, I am returning to TWiP from a cloudy 2 degrees Celsius, about 36 degrees Fahrenheit morning in Philadelphia. I am catching up on episodes after several weeks away to prepare for step 2. Oh, I'm wishing you the best if that's hopefully behind you. Parasitology was sadly underrepresented among the medical licensing exam questions. What a fascinating clinical case to return to, and thank you as always for the incredible review of recent research in Leishmania. This is a case of an older gentleman with no significant past medical history who presents with several months of isolated, progressively worsening abdominal pain. He grew up in rural inland China and moved to a large urban area in adulthood. He avidly consumes fish, cooked and raw, and leafy vegetables. We were not told he eats snails, but I'm not ruling that out. We also learn he loves to swim, including, I presume, in fresh water, given the rural setting of his childhood. He lives without other people or pets. He migrated to the U.S. 10 years prior to presentation, HIV negative. His physical exam is unremarkable, and lab studies reveal a neutrophil-predominant leukocytosis without eosinophilia, mild thrombocytopenia, and no anemia. Chemistries and hepatobiliary function studies are within normal limits. The abdominal CT reveals a colonic mass. A colonoscopy is performed. The mass is resected. Pathology reveals adenocarcinoma with, dun dun dun, eggs. Then we learn the eggs measure 80 microns in diameter, but we do not know their shape. Firstly, I suspect his abdominal pain is due to the evolving malignancy rather than his chronic parasitic infection. Now, for the parasite. Even without knowing the size of the eggs found in his colonic mass, the isolated gastrointestinal location of his infection, lack of associated eosinophilia, and its chronicity without deadly sequelae rules out nematodes who squiggle into human tissues like the terrifying rat lungworm and all filarial worms, including Wucheria bancrofti, which I would expect from exposure to mosquitoes in rural China. Eggs that are 80 microns in diameter, exclamation point. Which, if I'm not totally wrong, is way too big for any nematode. I remember roundworm egg size rounds out the range of average human lifespans around the globe. Wow, that's a nice way to remember. That is 50 to 75 years, and then I swap years for microns. So, what options do we have for non-nematode intestinal-only parasites that can hang out for over 10 years without causing noteworthy symptoms? Diphyllobothrium latum.
Good.
Okay. Guys, I'm so nervous. Okay, transmitted through saltwater. You know, I can't come on TWiP and mispronounce.
That was a beauty. That was a beauty. A+.
Transmitted through saltwater fish consumption is my favorite worm because of its incredible segmented appearance and the interdependence of its proglottids with central uteruses. Uteri? It looks like an alien to me. I'm not sure how big its eggs are, but I want to say big because it's such a big worm. I think he would have noticed ribbon-like ivory-colored strings of the large square proglottids sloughing off into his stools, and I imagine this would have caused him GI symptoms. Liver flukes. Even though he eats leafy vegetables, I'm not even giving liver flukes a second thought because he does not have biliary involvement on abdominal imaging. Liver flukes predisposed to cholangiocarcinoma, not colonic adenocarcinoma, because a theatrical attending taught me this on a recent rotation, and his description was so mesmerizing that I have not forgotten. Thanks, Dr. B. Dwarf tapeworm. I have no idea how large dwarf tapeworm eggs are, and this is common in Southeast Asia and could be asymptomatic, though he could have also had diarrhea, weight loss, and itch, especially perianal itching, or is that pinworms? I'm keeping this one in my differential. Oh no. Anisakiasis?
Good.
Okay. It's always what I think of when I think of undercooked oceanic fish. I received a video from a friend of a moving worm found on monkfish she was eating, and I was sure it was Anisakis. If she had frozen the fish completely prior to eating it, the worm would have died and she would have been safe. That or thoroughly cooking it. But these cause localized discomfort or allergic reactions, and people often feel something crawling in their esophagus. Then if you scope them, you'd see the worms wiggling around. Obviously recommend you see an MD, but I believe no need for an antihelminthic treatment. Let me see if I can share the video in this email. Now for schistosomes. Schistosoma japonicum and Schistosoma mekongii would make geographic sense for him. Maybe he had an acute infection long ago and does not associate it with his current abdominal pain. These can hang around for a very long time, and I know schistosome eggs get nestled into tissue walls. I think of lungs and bladder, and are inflammation producing and therefore could absolutely cause anything from an ulcerative colitis-like picture to colonic adenomas and eventual carcinogenesis. I hope to learn whether these species would be expected to avoid his lungs and liver. Nothing was said about bloody urine, or I would have thought about schistosoma hematobium, which I remember as S. hematuria. Okay, so if it's between dwarf tapeworm, Anisacis, and Schistosoma japonicum / McCongie, or some parasite I've yet to learn about, I'm going to pick the one that's most likely to give him adenocarcinoma. That's Schistosoma japonicum or McCongie. I'm going to say japonicum because I have a 50-50 chance here, and the name is closer geographically speaking. I was recently reading a paper about malignancies associated with various bacterial species. I cannot wait for your guest expert's appearance and to learn about all the carcinogenesis from parasites. I also would love to know if you or your guests have come across any research that would suggest that overfishing is contributing to a higher parasitic worm-to-fish ratio in the ocean. Thank you all so very much. You bring me so much joy in learning. Sara, MS4.
All right, so here's the photo she sent.
Oh, it actually is in there.
Yeah, it's not a movie, but this is what her friend had in fish, right?
Right.
Does it look like Anisacis?
Well, they all look basically the same, so there's
Yeah.
no way to tell at this point.
Okay.
I feel like there's a lot of pictures that pop up on social media, people at
Yeah.
a restaurant, and there's clearly some fish and the little
Right.
worm wiggling.
Right.
And the videos are ideal. I love to see movement.
Yeah.
Oh, yes.
They always have great production value, like on social media.
So
Exactly.
you then just send it back and say, just cook this well or freeze it? It's okay.
No, we won't charge you for the meal.
You see the worm, right, Christina? Yeah, you have it in the notes.
I
right?
can see the worm. Yeah. Richard, my husband is doing usually a field course on a little island off the coast of Scotland, and they always do a mackerel dissection, and they do isolate a lot of anisakis there, and he's got some nice videos of well, mackerel infested with anisakis. Quite well, not very appetizing, to be honest, but quite fascinating.
We have to come back to this question about overfishing and parasitic worm to fish ratio, and also carcinogenesis, if we can.
Yeah, we've got a lot, so
Yeah.
Go back to that. But meanwhile, Daniel, can you take the next one?
Certainly. Susan writes, hello TWiPers. Greetings from Seattle, where the weather is rainy in the mid-40s Fahrenheit. My oasis of sanity over the past couple of years has been micro.tv shows. I especially like the audience participation format in TWiP, but have been reluctant to submit an answer myself until now. The small number of submissions this week has propelled me into action. Shout out to Wikipedia. The elderly man who presented with abdominal pain has, I suggest, been infected with the fluke Basiolopsis buski, which is endemic in rural China, where he grew up and where he has continued to visit. Humans acquire this parasite by ingesting Metacercariae on aquatic plants and in infected water. Since this gentleman has a diet that includes many vegetables and fish, both cooked and raw, and visits an area where the parasite is endemic, it is reasonable to speculate that he could have ingested the organism. Abdominal pain fits possible symptoms of Basiolopsis. Diagnosis of the disease by microscopic identification of the eggs. The ovoid 80-micron eggs observed in the pathology sample are consistent with this parasite. This next paragraph is pure speculation. If I'm right, perhaps I may be lucky enough to beat Dixon to the pun line. The fact that you will have a special guest connected with this case on your next TWiP suggests to me that this gentleman himself might be joining you. If that is true, it was a fluke that the adenocarcinoma was detected and treated early. Thank you for all you do. The far-reaching effects of your efforts are immeasurable. Susan.
Christina.
Lauren writes, after watching a few TWiP episodes, I decided to give the Name That Parasite challenge a go. I'm going to name the parasite Xi, since the WHO avoided the name. A family name less common than Mu in China. All joking aside, I find this sleuthing to be quite challenging and educational. Clonorchis sinensis, my guess for this challenge, came up early in my search, but I originally dismissed it as the issues it causes are listed as hepatic and biliary. After going down a few rabbit holes and over a dozen research papers, I emerged with a better understanding and appreciation for parasites. They are both fascinating and creepy. I don't find parasites creepy.
No.
Well,
They
sometimes
may be
a
creeping,
little.
but they're not creepy.
Eventually, after a few re-watches of Daniel's case description and searching Wikipedia for adenocarcinoma, I was able to piece together that adenocarcinoma, cholangiocarcinoma, bile duct cancer, and colorectal cancer could all be synonymous. Call it a fluke, but I had my answer, and a bad trematode pun. At least that's what Xi said. Thanks, Daniel. It was an educational challenge.
Janine writes, my guess for this case is Schistosoma japonicum. The patient likely acquired the parasite in China. The pair of adult worms lived for 20 years, and clinical disease in humans is caused by a host inflammatory reaction to the many eggs produced by the worms. Hematobium eggs, which collect in the bladder, are well recognized to cause bladder cancer. It seemed plausible to me that inflammation in the bowel wall caused by egg deposits from the species whose eggs are excreted via the GI route could eventually progress to cancer. Google kindly provided some papers suggesting this is the case, and interestingly, it seems there is a stronger association with japonicum, the species present in China, compared with Montsoni. The size of the egg and ovoid shape, I think, is in keeping. Japonicum is more rounded than Montsoni and Hematobium. I did my DTMH, Diploma in Tropical Medicine and Hygiene, in Liverpool in 2011.
Good school.
And it seems I am out of date, as Google shows eggs of 5 schisto species, whereas I recall only learning of 3. If I win a book, I'm sure it will help me to update my knowledge. Take care. Janine is a specialist registrar in infectious diseases in Leeds.
Cool.
What is a registrar in infectious diseases? Does anyone know?
It's, I think it's like kind of between resident and then fellow, because sometimes they have specialized.
I see.
That's my understanding. Yeah.
Okay.
Ah,
Dixon, how did they find each other in the host?
delightful.
Yeah, I knew it. I'm glad you remembered that.
Well, I'm glad you thought to ask.
Very good. We're a good pair. We do good comedy together.
We do.
You're next, Dixon.
Kevin writes, Dear TWiP Tetrad, searching through Parasitic Disease 7, I saw that Fasciola hepatica and Fasciolopsis busci produce ovoid eggs 80 microns in width, but over 130 microns in length. The exposure risks, some freshwater veggies in China, and abdominal pain line up. And in PD7 notes that Fasciola hepatica is sometimes found outside of its usual liver lounge as a tumor mass. Fasciolopsis busci is normally in the small intestine, though in heavier infections it may be pushed into the colon. However, both of these trematodes generally result in an eosinophilia-dominated blood count. The kinostomid flukes have similarly plausible eggs, but similar results in eosinophilia. Clonorchis sinensis fits the geographic range and fish-eating habits and is noted for inducing carcinogenesis, though mostly notable bile duct cancer. Eosinophilia expected again, drat. Anasacids can be associated with colon cancer and raw fish consumption. However, the abdominal pain would be rapid onset, and the eggs and eosinophilia don't line up. Overall, I'm unsure, but I'll submit Fasciolopsis busci as my final answer. Cheers, Kevin.
Sara.
Yeah, dear TWiPers, I hope this finds you all well. I very much enjoy these cases. No rush sending out the book. I have more than enough reading for the principles of virology. The case presented in episode 201 is of an elderly man originally from rural inland China who later moved to a city and finally came to the U.S. This history would give him ample opportunity to inquire a variety of parasites. Fortunately, Dr. Griffin narrows the field of candidates by disclosing that the patient has a biopsy of a colonic lesion which is cancer-associated with 80 micron eggs. I did not know that parasites could do this, and I'm rather horrified. So the search is on for the creature. Strongyloides stercoralis apparently can be associated with malignancy in the duodenum and jejunum, and the eggs are bordering on the right size at 40 to 85 microns. I'm thinking it's not this one since the lesion was in the colon and the biopsy was obtained by colonoscopy. Schistosoma mansoni has been found associated with colon cancer, but the eggs are described as 115 to 180 microns, so the eggs are not the right size. Finally, Schistosoma japonicum, which has been found in association with colon cancer. This can be acquired by swimming in infested water. He might have come in contact with the parasite in his youth in rural China. The eggs are reportedly 70 to 100 microns, so this is my guess. Was it possible to resect the tumor by colonoscopy, or did he require a partial colectomy? It seems I was late to respond to the case, so I'm trying to be a bit quicker this time. Best wishes to you all, Martha.
Daniel.
Mark writes, parasitology was my favorite lecture and laboratory. My guess for the types of eggs and potential cause for the adenocarcinoma is Schistosoma japonicum. Schistosomiasis has been implicated as a cause for several cancers, including this type. I chose the species of schistosoma due to the egg size and endemicity coinciding with patient residences and travel. Thank you for your case studies.
Christina.
Christine writes,
Oh, my.
Dear Professor Racaniello, and Griffin, my name is Christine. I'm currently a fourth-year veterinary student at UC Davis, and I will be starting my pathology residency and PhD next year at Washington State University. The pathology portion of this case is what caught my interest, and I'm very excited to be writing in for the very first time. I suspect that the 65-plus-year-old man with abdominal pain and a colonic adenocarcinoma with parasite eggs measuring 80 microns present in biopsy tissue has schistosomiasis, more specifically Schistosoma japonicum. Schistosoma japonicum is a zoonotic trematode that is endemic in mainland China and that has been associated with liver and colorectal cancer. These intravascular flukes are acquired by skin invasion by swimming or wading in contaminated fresh water, where the infective cercaria, the larval flukes, are released from the snail intermediate host. I thought that this fits well with the history of the patient swimming in the river while growing up in China. Humans are the main reservoir of infection, but dogs, cats, rodents, pigs, horses, and goats all serve as reservoirs for Schistosoma japonicum. Chronic inflammation plays a pivotal role in carcinogenesis, as the eggs that are deposited in the large intestinal mucosa and submucosa result in severe focal inflammatory reaction. Over time, this chronic inflammation causes fibrosis, mucosal hyperplasia, the formation of polyps, and ultimately cancerous transformation. In addition to chronic inflammation, immune modulation, the mutagenic effect of schistosomal toxins, and bacterial co-infection, particularly with Salmonella species, may also play an important role in the carcinogenic process. Thank you so much for your excellent work on this phenomenal podcast. All the best, Christine. And she provides a few references to back up her guess.
Christine is president of the Radiology Club. Cool. Andrew writes, Kia ora from Pongaroa. My guess is schistosomiasis and most likely with S. japonicum. The geography works and the size of the eggs, big enough to poach, works as well. However, I don't think the carcinoma is a result of the infection, but rather the ova got trapped in the tumor, which had another cause. Off topic, Vincent mentioned in a Q&A with A&V short TikTok type videos, and it reminds me that Dixon is already a TikTok star.
Really?
Well, not quite, but Questella has a video of him reading pandemic poetry.
You do?
And she provides a link.
I don't believe this.
Well, maybe we could...
Can we go to that? I'm excited.
I do
There
not
he
believe
is.
Oh my gosh.
He's reading pandemic
In
poetry.
Wuhan's caves, the virus grows. Within the bats hung row by row. They hang by day, they fly by night. I like this.
Dixon, must have been you reading one of the poems for TWiV, right?
It's possible.
And she cut this out of the video.
It's
and
possible.
Put
Made
it
a
on
TikTok.
TikTok. Yeah, watch TWiV.
Ha!
It's from TWiV.
I'll be darned.
I can't get the sound here, but oh, that's cool. Very nice.
I like that. Well, if anyone wants to make TikToks of me, I give permission. I love. That's one of my goals in life, to be a TikTok star.
And they accused me of not knowing what time it was.
Then my children would listen to me, right, if I sent them a link.
Should you ever consider expanding Microbe TV to TikTok, then short selected questions and answers from Q&As could work well. In short 1 to 3 minute formats they allow, that is a not so subtle hint for a TWiP Q&A. Yeah, we could do that.
It may be fun to try to add funny answers to the questions, too.
Yes.
But we do that anyway.
Not even on purpose.
Not even on purpose. That's what I was driving at.
I look forward to 2022 with lots of intriguing parasites. And
My goodness.
We're back to Dixon, right?
We are. Elise writes, Dear TWiP Quartet, Happy New Year and many best wishes. While it was a super humid 65 degrees F yesterday, 13 C, the temperature now is at a rather bleak 28 degrees F, minus 2.2 C, with gray skies and a pretty sharp wind. While yesterday felt weird, it now feels definitively January-esque. I'm writing quickly with a guess diagnosis quickly because if I don't know something or someone will get in my way and I'll miss yet another month of guessing, which is unacceptable. I suspect strongly that the patient's abdominal issues were caused by the cancerous mass in his colon, which in turn was caused by schistosomiasis. My further guess is that this is schistosoma japonicum infection. Even though schistosomiasis is not found in New York, or really in the United States, the patient grew up in rural China, where it is endemic. I suspect he became infected with the parasite in China and had lived with it for quite a long time, long enough for the infection and irritation to create the cancerous mass. The eggs discovered in the mass are also consistent in shape and size with schistosoma japonicum. I do have a question about the patient. How long would he have to harbor the infection before a cancerous mass developed? How does the cancer develop? Is it really the product of relentless irritation of the infection? I did find quite a number of articles about people whose schistosoma infection did develop into colon masses, thus my diagnostic guess. But how long does this take? Also, once the mass is removed, was the patient also treated for schistosoma infection, or was the mass removal sufficient? Thank you so very much, as always, for your amazing work. It is always such a happy distraction for me to get to hear or watch your podcasts and attempt my amateur detective work. Best wishes, Elise, in Lower Manhattan.
As opposed to the Incubator, which is in Midtown.
Midtown. This is exactly right.
Sarah.
It's in the belly of the beast, as it were.
Owain writes, Dear TWiP, your plea last time for more guesses made me feel very guilty. I haven't guessed in a while, in part due to moving flat, and in part due to finishing the dissertation component of an MSc in medical parasitology, which your podcast definitely helped inspire me to pursue, so thank you. Hopefully that's not too bad an excuse. My guess for this case is that paragonymous eggs were found in the biopsy samples. They're the right size and shape, and most of the other raw fish/vegetable acquired helminths I could think of don't have eggs the right size. I did consider schistosoma japonicum, but think it's less likely as it's been a while since he lived in rural parts of China where he would have picked it up. Hopefully the reduced guess numbers improve my odds of a book. All the best and Happy New Year, Owain. P.S. As a fellow Stargate fan, I enjoyed Daniel discussing symbionts at length in episode 200, given how heavily they feature in the show.
Daniel.
Okay, this is from the Parasitology Club at University of Central Lancashire.
Lancashire.
Lancashire. See, he's here to correct you, so you don't have to worry about
I'm not
pronunciation.
correcting you. I'm just offering an alternate explanation.
He should do it gently. I've often heard other people pronounce it this way.
That's right. The next time you say that, say it this way.
Happy New Year and greetings from the Parasitology Club at University of Central
Lancashire.
located in the currently wet and cold northwest of England. This was appearing to be a tricky case until Daniel revealed that slightly oval 80 micrometer ova had been found in tissues of the colon, and linking this with a childhood in rural China, we immediately thought of schistosomiasis. Referring the parasite ova identification chart in PD7, and reviewing the geographical distribution of schistosoma species, we think that this Chinese gentleman may have been living for many years with an historic infection with schistosoma japonicum. Wang et al. 2020 described infection with schistosoma japonicum as a critical risk factor in development of colorectal cancer from a study of over 220,000 Shanghai County residents aged over 45. It is exam season, so we will keep our responses rather brief, but we are constantly grateful for the challenging and fascinating case studies to help us learn more. David.
Oh, that's it.
That is it.
Well, that's a good crop of guesses.
That's a very good crop. With
Sarah,
some
are you
extensive
impressed?
answers.
I am.
Yeah, we have good listeners.
Yeah.
There was a question here, most recently. Here. All right, well, why don't we do the review first, then we'll get back to these questions. Okay.
Well, I think we have a few more people that get to guess.
Oh, okay. you, Dan, you'll have to guess, right?
Well, perhaps I'll recuse myself, but I will get involved in the discussion.
All right. What about Christina?
Christina, do you want to start?
Yeah, so I was thinking about that for quite a long time, and I was really interested to read those many different Helminth diagnoses that we got through here today. My own guess was with schistosoma japonicum because of the history, because of its association with the development of colorectal cancer, and also the case history. So having lived in China, in rural China, and we have been swimming in the, I can't remember now, swimming. So that was the guess that I thought was the most fitting for me. The eggs are about the right size, although I thought they were maybe a smidgen bigger, and they're about the right shape. You didn't mention the little spine, but then that's not always very easily visible on microscopy. So I was happy with that. I was quite interested to read the strongyloides guess as well. That's not my guess, but I just never thought of it because I never think of strongyloides eggs because they are not diagnostic. But I looked them up and they are actually also the right size and right shape. But I think other history factors and symptoms don't quite fit with that one. So I think I'm going to go for schistosoma japonicum, but happy to be wrong.
Dixon, what do you think?
I concur. I would. I was always impressed with the fact that patients that come to the hospital, particularly Columbia Presbyterian Hospital, never came with just one thing. They had multiple infections or multiple diseases that affected the way you make the diagnosis. And in this case, if this gentleman hadn't started to suffer from abdominal pain, he may have died from this carcinoma at home. The schistosoma japonicum diagnosis was pretty straightforward because, again, I was challenged by the size of the eggs to go back to our very own textbook to try to find an egg the right size, and the only one I could possibly come up with was schistosoma japonicum. The discussion that Sara and I had in the next room during another preview podcast while you were busy talking about
and you may be able to hear this in the background of TWiV COVID Clinical Update. We'll have to see.
That's right. That's right.
I gate crashed that as well. Did you notice it?
I was discussing with Sara when I was a lab technician at Dr. Harold Brown's laboratory in Columbia, the adjunct hospital diagnostic lab, I should say. We were taught how to tell in a biopsy whether the infection was old or new. And the way you know is that you can see the eggs as either calcified units or the egg is intact and you can see lots of structure inside the egg. And if you make a biopsy rather than a section of tissue, and you do a rectal snip rather than a rectal biopsy, you can then press that piece of tissue between glass slides, and using your high magnification, you can look inside the worm itself, which is an embryo inside the egg. And on each side of the egg, there are symmetrical excretory pores. And inside the excretory pore are two little cells that are referred to as flame cells.
Yes.
And these flame cells are quite unique because if the egg is alive, you will see what looks like my fingers going back and forth like this. Can everybody see that? And that's what the flame cells look like. So you know it's at least an alive infection. The infection is not an old infection in the sense that the adults are still there and they're still giving off eggs. Whereas if all of the eggs look calcified or if the flame cells didn't move, you might want to conclude that it's an older infection. And that raises the question of whether you should treat. Let's say you resectioned the bowel and took care of the adenocarcinoma. You're now worried about the parasitic infection. And should you treat that parasitic infection or not? And to know that would have been convenient for them to have taken a biopsy, or a SNP, I should say, send it off to the parasite lab and see if they can do a flame cell test. And that often is the determiner as to whether treatment is going forward. That was before praziquantel, by the way.
Yeah, I was thinking you'd almost have to be thinking about this ahead of time, right? Because when you start presenting the case, I have to say, like, it gets presented. I'm not thinking one of these parasites, right? So abdominal pain, guy from China, got a mass. They say, "Oh, Dr. Griffin, it's a parasite." I know what I'm thinking, and it's not necessarily.
It's Clonorchis. I was thought Clonorchis.
I was thinking actually amoeba. And we've seen that.
We talked about that
I got
too.
a call for that. So gentleman had this mass. It looked like the apple core, right? So they do the barium enema.
Right.
Then they do the CAT scan, and they go ahead and they just go right ahead and do surgery, and they realize it's an amoeboma. So this person had. Amoebiasis, but in this case, I don't think people would have been necessarily thinking about this before they went in.
No, that's right.
And that's tricky, right? Because what are they going to do? They're sending this off for pathology, for margins, for understanding the cancer.
That's right.
They're not, and then they're like, "What are these?" So let's call ID in the middle of the night.
That's right. Well, fortunately, my lab was on the floor above the pathology lab, so they knew where I lived, and they used to come up all the time and ask me to come down and look at slides and stuff. So I've learned a lot from pathology residents and staff members too. So this is a great case, by the way. It's a wonderful case.
And I guess I would say, so amoeba, we're not thinking at this point, right? Because we're not going to see eggs,
No, that's right.
That's right. Protozoan, cysts, etc.
The other thing is you should look for the eosinophilic invasion too, right? In the amoeboma, it's largely eosinophils.
Yeah, that's
So
true.
in this case, they didn't say that, so that probably wasn't. It was neutrophils, as they said, right?
So Christina mentioned strongyloides. What about that? Why
Well,
is
the eggs of strongyloides develop so fast that they don't look like eggs anymore. They look like a larva inside of an egg.
Okay.
And you would have seen that right away. And you might have even seen larvae in the general area if that was the case. If this was such a heavy infection for strongyloides as to go from the small intestine to the large intestine, that patient would have been dead by now.
Yeah, and I think that's the localization too. I mean, the strongyloides is autoinfection, so I guess we'll sort of go through. So strongyloides penetrates the skin. It's really going to be a small intestinal autoinfection.
That is exactly
cycle.
right. Exactly right.
So yes, to see this in the colon that just didn't raise, and as you bring up, either they have eosinophilia. Or they don't because they're septic.
That's right. So
that's
right.
Yeah, not quite the right presentation. I like the thought of the clonorchis, but I'm thinking we're in the wrong place.
Wrong size eggs also.
Yeah, wrong place, wrong size eggs. So I like schistosoma.
Yeah.
I like japonicum based on the size. I think macongai be considered in there.
Isn't that much
Manzoni, right?
smaller,
It's a size issue.
I think the egg is smaller from Mekong.
Yeah, so different size.
I really wanted it to be Mekongai because we've never seen that.
Yes, no, I hear you. And besides, it's restricted to the Mekong River and
It's
the
kind of
Mekong River
Laos
Delta.
as well, so it's not in
So
mainland
it's not
China.
quite Japonicum. It's Japonicum-like.
Yeah, so geography, size of the eggs.
Right.
And I think it's also interesting, and we're going to find out if this is schistosomia soon. But thinking about, the different life cycles. So the flame sign is actually something, when I was in Malawi, right, trying to figure out with schistosoma hematobium, someone's been treated, they still might continue to pass eggs, but are they alive, right? People want to know. You keep throwing praziquantel at them, which you could potentially do. And that flame sign is going to allow you to look under the microscope.
That's right.
Are they still viable?
Exactly.
Or are these just old eggs and they're still passing a few out? So you're thinking of that going to be really bladder, right? But then you start thinking japonicum, you start thinking Mansoni, and that's up in the mesenteric. That could make sense for colon. So I think all that kind of makes sense. And then thinking about exposures, right? I mean, this is my wonderful, like I go swimming in Lake Malawi and I just towel off really vigorously so that it doesn't penetrate my skin. And
Or so you think. I remember when we first met, he told me that story. And I said, you weren't worried about your kids catching schistosomiasis? And they toweled off really quick. Come on.
we were mainly worried about the crocodiles, like the lifeguard. There's lifeguards there. And I'm like, so when you swim, what are you doing here? And he's like, well, if I start yelling, it means a crocodile's getting too close.
Exactly.
I'm like, too close? How close is too close?
One human body length.
Toweling off vigorously was the name of that episode.
Yeah, that's right. So another point to make here is that with Schistosoma mansoni, the adult worms usually localize in the small intestine. They usually don't get into the large intestine at all. But Japonicum can go into the brain. You can have a Japonicum infection at the end of your finger. They go all kinds of places in your spinal cord.
Yeah, spinal
You
cord.
can start to develop neurologic symptoms associated with loss of function. And so finding them in the large intestine wouldn't be a surprise.
Yeah. So I think, Vincent, what are you thinking?
Well, I came up with both schistosoma and strongyloides. I didn't realize the egg issue with strongyloides because both have been found in intestinal
Absolutely.
cancers, right?
Absolutely.
But it sounds like schistosoma makes a lot more sense.
Yep.
Sarah.
That's right.
So,
It'd be interesting to have a mixed infection of strongyloides and Japonicum.
everyone, you guys got it. So we eventually it was ID'd as schistosoma japonicum. The problem was it was an incidental finding. You're talking about how helpful it is to know what you're looking for when you go in. So none of our sections on PATH had this perfect image of the egg to either see the spine or know exactly what it was. So we really had to use sort of epidemiology and the size of the egg, and sort of that's kind of how we got to Japonicum. And so he was planning to get chemotherapy after the resection, and so we ended up treating with praziquantel just, in an abundance of caution. My suspicion is that this was a old infection that had been chronic for a while, but how much that's related to his current adenocarcinoma was hard to say. And everyone did a really great job bringing up how there are some studies that are, looking at could schistosoma cause adenocarcinoma in the colon. And, the info out there is a little bit mixed. A lot of them are sort of, let's look in this area that is endemic for schistosoma, and then let's look and see how many people had colon cancer, and they do link up, and it's all those studies are always hard to interpret, but it seems like maybe there's some signal there. And so, I still, at the end of the day, it was still an incidental finding, but very interesting. And I will say they called back much later after the colon resection. He had an ileostomy takedown. So basically they kind of reconnect everything, and there's pathology sent again, and there were still eggs.
Sure.
And this was a year later.
Oh, wow.
And at that point, he had some chemotherapy, and he had done fine and had no issues. So we felt even more confident saying, those eggs are there, they're hardy, and they're hanging out in that path, but I don't know that it's causing him any issues or that we need to retreat. But I felt like I learned a ton of different lessons, and certainly don't see much schistosoma in my usual practice. So this is a really interesting case.
Right.
Where are the schistosomes harboring in him?
So I don't know. We were talking about this because they resected a large part of his colon, and I don't know if when they removed that, because they also removed some of the vasculature, even if there had been worms in there, if all of that would have been removed. I think it's an interesting question. I don't really know, but
Dixon?
The worms, if you don't mind me
Yeah.
adding something to this discussion. The adult worms always live in blood vessels of some sort, so they've got to be in the mesenteric vessels.
Yeah.
Right. An interesting case at Columbia, just in passing, a cab driver who happens to have the name Ahmad Jamal, I could remember that forever as the famous piano player, came in with a gunshot wound to the abdomen. They resectioned his gut, of course, and then they sent it off, and they discovered that he also had schistosomiasis. He was from Saudi Arabia.
Wow.
So it was just an incidental finding, but still, I mean, you have to get shot in order to get diagnosed. That's incredible.
Yeah. And I think the idea, right, is so they're in there and they're in copula most of the time.
All of the time. They don't give up. They do not give up.
Apparently, and I will, just a little bit of trivia, apparently every so often they do separate, and even though everyone thinks they always go back to the same mate, that may not be true.
They're not like swans.
A little bit of scandal there.
Well...
but they're actually sort of a tight forming where the eggs are ending up hopefully in the feces, but that can sometimes be a little bit disrupted and then it can be sort of washed away with the circulation. So,
how would the eggs get to the feces?
actually, it's going to penetrate through the wall, so they're going to be in tight.
Thank you.
Daniel, we need a name for the combined schistosome strongyloides infection.
Yes, I'm now naming, Flurona. This will be schistoloides. Yes.
Schistoloides, yes, that's a nice ring.
Yes.
We'll see if it takes off.
They've made a song with the Flurona. My Flurona. No, I'm joking.
Elise said, how long would he have had to harbor the infection before a mass developed?
I don't think we know the answer to that.
I don't think this mass is due to that infection, so that's a red herring question.
It's a red herring question. Okay.
10 years at least.
It's like the other question is that's like that is how often do you beat your dog? And you can't start to answer the question because it's not.
Yeah, no, I mean, I think, our understanding of cancer, starts as a polyp, progresses. That's many, many years. That's why we screen every 10 years, because it's more than 10 years. But yeah, I'm not sure, right? And I think we've sort of discussion how much of a connection. Is there really a chronic inflammation? Is it really increasing our risk of cancer?
There was another question here.
The overfishing question.
Overfishing contributes to high parasitic worm to fish ratio.
So let's describe how Anisakis is acquired, okay? So Anisakis is actually an adult parasite of cetaceans. Mm-hmm. So orcas and pinnipeds also, the seal family. So you've got whales and seals as the mammalian host for these parasites. So their eggs are released from the adult worms in the definitive host, the cetacean. But the eggs then are ingested along with the detritus that comes out of a cetacean, which is in some cases a lot, like a blue whale, for instance. Yeah. So the eggs are picked up and swallowed. They hatch in the fish, and then they burrow into the tissue, and they develop and stay there as the infectious third stage of this nematode infection. And overfishing, let's see, what would overfishing do? It would mean that of all the fish that are possible, if you reduce that by 80%, the 10% that are left would probably have a larger range of food supply. Mm-hmm. So I would suspect that they would be less infected than more infected.
I'm almost thinking the impact on the cetacean population is going to be a problem here because you're removing that from
That's right.
this.
They switch. Like orcas. Orcas are omnivores in terms of their prey. Some only eat salmon. Some only eat seals. And some only eat baby whales. So that's...
Sorry.
No, jump in.
Yeah, I was just thinking, whatever feces comes out of a whale, it'll be diluted so much.
I sure hope so, or I'm never swimming in the ocean again.
I'm just imagining it would have an impact on, because it would be so dilute, really.
And yet
it still works.
And yet. Yeah. Well, imagine how many dolphin there are. Dolphin are cetaceans. So when you see an enormous school of dolphin, I've seen a nature show with David Attenborough where there were 5,000 dolphin in one pod.
Wow.
I mean, that's a lot of dolphin. And what were they doing? They were running after the mackerel and the herring. And you can imagine what happens after they finish decimating those shoals of fish. They defecate like crazy. So there's a whole ecology associated with predator-prey and parasite and host relationships that are quite interesting to think about. I'll
Mackerels
do more
are heaving
thinking.
with anisakis, as we know from local experimentation.
Yeah. No shortage.
The dilution
None.
is great, Daniel. Don't worry about it.
And
It's going to be okay. I can swim with the whales and the dolphins. Stay off to the side next time.
you're fine. You're not a fish, so that's okay. I would worry more about the orcas thinking you were a seal.
Yes, yes.
You know, infected whales can excrete 10 to the 13th caliciviruses a day
Look at that.
Yeah.
because it's a gastrointestinal infection in them, and so it's a lot, but the dilution is huge. In the ocean.
The dilution is
The
huge.
solution to virus in
Yeah.
the ocean is dilution.
But in
Solution
some
is
cases,
delicious.
no,
It doesn't rhyme
The
that
take
well.
home.
you've also seen the nature shows where there are humpback whales feeding in groups, and they go down below the shoal of fish, and one whale then sends out a row of bubbles, and it forms a net of bubbles around the shoal of the herring, and the other dive into the shoal, and they all come up together, and they're eating and defecating for about 3 months solid.
All right.
And that's in northern and southern climes. So
Yes.
that, the more whales there are, I think the more of this you're going to see. That's what I think.
But Dixon, that's a good cycle, right?
It is.
The feces they excrete
course,
gets
of course.
degraded and used, and so forth.
And it's a
Yeah.
fertilizer for the algae in the
Yeah.
ocean and everything else. So it's part of the natural cycle, obviously.
All right.
It's a great image in our minds.
Yeah.
Indeed.
There goes
Should we,
my
should we give away a book?
Yes.
First thing for dinner, right? No.
That's right. That's right.
We're getting sushi,
What
right?
is for dinner? That's right.
Get sushi. It's time to give away a book. Yeah. So we had 10 guesses, and I think I excluded some of the people who had won before. But if I do make an error, just let me know. So we have a random number between 1 and 10.
Are we
All right.
ready?
Are we ready, Dixon?
I'm ready.
How can it be 10? How can it be 10?
That's not really between 1 and 10.
Well, it is, right? Well, that's what came up between 1 and 10 is 10. Because if I do it again, I get a different.
Okay.
All right, so it's number 10, which is the Parasitology Club at the university.
That's a
And
great use for a book.
even if they've got one before, they should let us know how many they want.
Absolutely.
Yes, so Parasitology. You probably haven't gotten your other one yet because they haven't been
That's
mailed
right,
out.
Mel. The mail is slow during the pandemic.
But they are in the next room, signed and ready to go. So
We have an
I
excuse.
did see
Tell us-
them in person.
to bring them in person, yes. Tell us where to send them. Send it to TWiP at microbe.tv. Dixon, yes, Christina,
I
go
can
ahead.
bring it in person. I'm almost local.
You bet.
I don't have a signed
Central-
copy. Well,
You're,
just a few hundred kilometres. It's not very far.
Yeah, right. Central Lancashire, huh? Is that south of you?
Yes.
All right. Dixon, you have a hero?
I do. So we've actually featured her in our book, but we have not featured her on TWiP.
Oh.
So we were about to do that. Her name is Eloise Blaine Cram. She was born in Davenport, Iowa in 1896. She graduated Phi Beta Kappa from the University of Chicago in 1919 and received her PhD from George Washington University in 1925. In 1920, Dr. Cram entered government service as a zoologist for the United States Department of Agriculture's Bureau of Animal Husbandry, where she gained prominence as a world authority on the parasites of poultry. Those are still present today, and trust me, that drives the industry. She eventually became the BAI's head scientist for the investigation of parasites in poultry and game birds. In 1936, Dr. Cram left the BAI to take a position at the Zoology Laboratory of the National Institutes of Health, where she spent the rest of her career. While at the NIH, Dr. Cram contributed to the studies of pinworm and other parasites of humans. She made major contributions to parasitology and to the science in general, with her pioneering research into the disease schistosomiasis. Her studies of the snails that transmit this often fatal infection to humans helped reduce the disease's public health threat. By the time she retired in 1956, Dr. Cram had published over 160 papers and monographs on various subjects in the field of parasitology. She was recognized as an international authority on helminths, worm parasites, diseases. In 1955, the year before her retirement, she served as a term as the first woman president of the American Society for Parasitologists. She died in San Diego, California on February 9th, 1957. And that's our hero for this TWiP.
Thank you, Dixon.
Welcome.
She even has a Wikipedia page. There we go.
Well, most of that came out of there.
There you go.
Yeah.
There's
That's
a
right.
photograph.
I like that photo.
That's a great photo, isn't
Yeah,
it?
It
it's
is.
so good.
It truly is.
It says,
I think that's the one that's in the book.
Yeah, I think it may be
that's
the
right.
same photo.
What is
yeah.
she doing there?
She's dissecting.
What?
I don't know. It looks like a frog from here.
Yeah, I was looking earlier. I couldn't tell if it was a frog.
But yeah, it's
Is it
kind of
a
ropey.
tail, maybe?
It might.
This looks like there's some tail, but it might be the wrong
It might be a two-dimensional rat.
I don't know.
Interesting.
Very cool. All right. Thank you, Dixon. And now, before we move on to our new case study, Sara, just you're part of this Febrile podcast. So tell us about that.
Yeah. Thanks. I started, we've been going for about a year now, and the idea was to create a podcast that focused on infectious disease clinical reasoning and sort of just good learning cases. So it's a case-based podcast, and we talk through, there's an expert discussant, and usually myself and or a co-host or a learner of some kind presents the case, and we sort of just pause along the way to hear their thought process and both sort of thinking through what the infection could be, but also how do we manage it in some of the more complex cases. And so my goal is to have everyone love infectious disease, but also, try to highlight a lot of the really awesome trainees and faculty that are out there doing infectious disease, because it's not all COVID, even though it seems like it. So if people want to listen, I took a quick break, but should be coming back at the end of January.
So do you record in person or over Zoom now or something like
All
that?
remotely.
Remotely? But
Yeah.
it was originally remotely because you started it just a year ago, right?
Right. Yeah. So the good thing is everyone's so used to hopping on Zoom that it made the transition pretty easy. So we've had people kind of come from different parts of the states and then hoping to slowly expand.
Are you going to keep doing this throughout your career, you think?
I hope so. That's the plan.
All right. Very good.
Yeah, it was actually one of my partners, Anuja Lee, was a big fan, and she introduced the podcast to me, and so I started listening and been enjoying it. And it is nice. It's fun to hear like real cases, people going through the thought process.
Yeah.
It's a great educational resource. So
Yeah, thank you. Yeah, we have a website. We try to do a lot of infographics that people can use to study, whether or not that's for boards or if you want to teach something on the fly when you're on rounds or seeing a patient. So I'm hoping that in addition to the podcast, there'll be a lot of things on the website or through the graphics that people can use both for learning and for teaching.
I really enjoyed the syphilis one. I have a special place in my heart for sexually transmitted infections.
Yes.
But that was a very dynamic one. I enjoyed.
Yeah, Dr. Gavin is very passionate, which is great. Yeah, I've been lucky to have some really wonderful guests on the show.
I do really like the titles of your episodes as well.
Thank you. And I probably spend more time on those than I should.
Can't beat that one.
That was a good one. I like the Tale of Two Poos.
I think I'm going to
And the
listen to
names
that
of the pets. The pets all have great names.
It's the best part.
Yes.
Who framed
Yeah,
the
we have
rabbit?
fun with our titles too.
Yeah.
All right. Now, Daniel, do you need your laptop to do your case?
No.
This
This is in my head.
All right.
I have notes here, but I actually feel like I remember this one quite
right.
well. So I'm going to do
I'm
this without
excited.
notes. So this was a case that I was asked to consult on just last month, so fresh December. And this individual is a gentleman about 60 years of age, and he is a shopkeeper in an interesting setting. This is the Rohingya camp for displaced Myanmar natives. Now, other people
wow.
might call us by different names, but that is what the Bangladeshi government has me refer to this place. Maybe 1 million individuals living in this area, Cox's Bazar. So this is, if you think of Bangladesh, this is sort of down in the southern, eastern, it's right on the border there. And so this individual, it starts with about 3 months of he's getting up at night, he's urinating a lot, so frequent urination. He's really thirsty, he's having a lot to drink. Notices he's starting to lose some weight. Doesn't really think much of this. And then he develops a rash. So he's got a rash. It's on his elbows. It's on his abdomen. Just incredibly itching. He's scratching all the time. Now the rest of his family has this same rash as well. It's between his fingers. It's keeping him up at night. All right. So far, so good. No need to see the doctor yet. Then this gentleman starts to feel kind of a little bit crummy. Starts with a fever. Starts with a headache. Starts to feel not so great. Now he starts to cough. Now he starts to have trouble breathing. Finally decides, hey, it's time for me to seek medical attention. So now I will check my notes. So it's trouble breathing, and now he finally goes to the medical center that I consult for. So when they see him, they see this man. He's obviously having trouble breathing. They sort of pin things down. He felt crummy for a little over a week, but now it's in the second week, and he's having trouble breathing. His oxygen saturation is down in the 80s. And what are we thinking is going on? So past medical, past surgical history is pretty healthy individual. Let me just make sure I'm not missing anything. He is a bit of a heavy smoker, right? Because we have our toxic habit review. He is HIV negative. As far as the social, right? He's living in one of these dwellings. A lot of the dwellings have these tin roofs on a dirt floor. His is a little nicer. He's a shopkeeper, so sort of in the scheme of things, his dwelling is a little bit nicer than some of the others. But a lot of people crowded, living with family. He's not really the only one who's coughing and feeling crummy. There seems like there might be some kind of a viral illness sweeping through the camp. Several other people have ended up in hospital. 85%, as I mentioned, on room air. On exam, he is working a little bit to breathe. Otherwise, abnormal pulmonary exam. Heart rate is a little bit increased. Elevated white blood cell count. We don't have a differential yet. And he is noticed to have elevated glucose in the 300s. So at this point, they're going to do a number of diagnostic testing. And I'm going to sort of ask our listeners to weigh in on this man may have more than one thing going on. So what is going on with this 3 months of frequent urination, thirsty, something developing? What is going on with this rash that is spreading, that his whole family now has, that is incredibly itchy? Is there a parasitic thing there? And then here we are, December, in a crowded camp. What might be causing this gentleman to become hypoxic and bring him in?
So he's living with his whole family, right?
Whole family, they're all together.
And they get this second half, but they don't get the urinating and thirst and all that.
So they don't have that increased urination. They all do get the rash. He's the only one, he's the sort of the senior in the family, so he's the oldest individual. He's the only one that is now showing up having trouble breathing.
Okay. And what do they eat? Do they eat in their own domicile? Do they go somewhere else to get food?
They all cook usually themselves, so they'll have these little sort of ability to make a fire and cook things, so there's some ability to cook. Food is always a bit of a challenge, sort of living hand to mouth, so it's not...
Do we know what kind of foods he eats?
Really whatever's available, so it's,
Whatever they give him.
Yeah, whatever he can. These are pretty tough
You sure
circumstances.
1 million people living in one place?
So that's the most recent estimate I heard. Yeah, it's really, the aerial views of the place
incredible.
are just incredible, just to see the tin roofs just
That
to
is
go
amazing.
on. Yeah, I think I did a lecture for University of Glasgow where I actually showed a photo of this camp.
Goodness.
And so
So sometimes you go there?
So far it's all been remote.
Oh.
So because during the pandemic and with some other things going on, I'm hoping at some point to actually get there. I mean, I've gotten to know when I do these consultations, I do them. It's nice with the time change. I think it's nice. I can wake up before everyone else wakes up, and I can get my infectious disease consultations for Bangladesh in before my other work day starts.
Sure.
And so I get on the call, 20, 30 clinicians on the ground there. We go through cases.
Who's supplying them with food then?
Part of it is aid, and part of it is sort of this local economy that develops.
Wow.
Yeah.
Not a great situation.
All right. I'm good. Are you good, Dixon?
Yep.
Sarah? Christina?
Yep.
Everybody's good?
Good. Yes, thank you.
You
All
bet.
right. There's no 80 microns here.
No. Not at all.
All right. That'll do it for TWiP 202. You can find the show notes at microbe.tv/TWiP. As I mentioned earlier, if you want to support us, TWiP is part of the Microbe TV family of podcasts. Go over to parasiteswithoutborders.com through the end of January. They will match your donation. Or if it's after January, you can always go to microbe.tv/contribute. We are a 501c3, so your contributions will be tax deductible. Give a lot of money, you can deduct it from your taxes.
It's true.
And we put it to good use here. We have built this incubator, which we hope to get bigger and do more and more science communication. Our guest today, Sara Deng from Febrile Podcast. Good to have you, Sara.
Thanks for inviting me. I had fun.
Yeah, we had fun.
And I got to check out the incubator.
We're usually
Person?
not together. This is pretty rare.
This is
This
true.
is special.
But
Very special.
hopefully as time goes on, we will be here more often.
That's
Yeah.
true.
Although, when Dixon and I started TWiV, he used to come to my office to record.
Absolutely.
And then the others would come in. on
First, you
Skype.
used to come to my office.
Yeah, the
Remember?
first one was your office, yeah. And then we brought in other people by Skype. And then Daniel used to come in.
Yeah, just come right
In
over.
fact, for TWiP too, you and Dixon would come to my office. And
Yep.
that all stopped, of course. But hopefully we can do some resumption of that
You bet.
in the end. Dixon et Pommiers at Tricanella.org, thelivingriver.org. Thanks, Dixon.
It was great being in the incubator.
You can come back.
We saw a lot of growth of things in the incubator.
Yeah, come back. The incubator is so named for a good reason.
You bet.
Someone asked me last night, can we do some experiments there? I said, no. We do this live stream on Wednesday nights, and I said, my company's designed a face mask that has copper in it. And he said, could we test it at the incubator? I said, no, we don't do that here.
Not that kind of incubator.
So, people may think it's a lab, but it's not a lab. It is a lab for science communication and education,
Correct.
but not for other things. So, sorry, but you can find other people to do that. Maybe Daniel wants to test your copper-containing. Christina Naula is at the University of Glasgow. Thanks, Christina. Good to see you.
Yeah, it was good to see you, and it was also really good to see Sara. What an interesting case you presented for us. Lots of thinking, really interesting. So, yeah, I had great fun.
Daniel Griffin's at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thanks, Daniel.
Pleasure.
I'm Vincent Racaniello. You can find me at virology.ws. Music on TWiP is performed and composed by Ronald Jenkins. You can find his work at ronaldjenkins.com. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP is parasitic.
We almost got it.
That was well coordinated.